Karen can start her presentation.
Okay, from our past, I would like to introduce Dr. Professor Nguyễn Văn Minh, Chief President our department. So please, Dr. Minh, can you open the camera? Yeah. And my
Hello.
name is
everyone.
So from Stanford University, I would like to introduce Dr. Sarah Strauss and Dr. Karen Ann Lacko and Dr. Hannah Scott. Yeah. Welcome all of you to our virtual rotation. Yeah. And we have 2 weeks together. Yeah, with some lecture and case study too. Discussion later on Friday. So today we start the first lecture in GA in OB, right? Yeah, and I would like to introduce Dr. Karen Ann Olako will present the lecture, please.
Awesome. Hi,
you
everyone.
Have to speak. Sorry, you are any more strict, Professor Min?
Okay. Hello, Dr. Sarah Stroh, and hello, Dr. Olaka and Scott. Welcome all of you to the International Virtual Rotation. And on behalf of the department, I would like to express our thanks to Dr. Sarah Stroh for your time and for organization, so that we my friend and welcome Dr. Karen Ann Olako and Dr. Anna Scott. And I think it is a good opportunity for our resident and our colleague. And we stay in Vietnam, we learn and we work, but we can experience the practice in USA. And I think it is also a good opportunity for our residents to share the cases that they has in practice, and they can freely poll on the question, so that they can learn more from you. And again, thank you very much for your time and your energy and your preparation in the next 2 weeks. And thank Dr. Tan for your time, for your enthusiasm, and thank you.
Thank you, Professor Min. And you can start right now, Dr. Olanko.
Thank you so much for the welcome, everyone. I'm Karen. I'm one of the CA3s, or I'm in my final year of anesthesia residency here at Stanford. Hannah, I don't know if you want to introduce yourself.
I'm Hannah. I'm also one of the CA3s, or I'm also in my final year of anesthesia residency at Stanford as well.
Awesome. Okay. Hopefully I figured out this screen share. Thank you everyone for joining. I'll be talking about general anesthesia in obstetrics today. So I figured we could start with a small case. So you're on call on Saturday night on the labor and delivery unit, and the obstetrics resident or the OB resident calls you regarding an urgent cesarean section for a patient in early labor. And so she's a 34-year-old G4P3, meaning she's had 4 gestations and 3 kids at a gestational age of 38 weeks and 2 days with 3 prior C-sections in Ecuador. She also has a placenta previa. Why is the C-section urgent, and what are you concerned about? So today we'll be talking about a few things to kind of round out the discussion about GA and OB. So we'll start with the physiologic changes in pregnancy and the anesthetic implications of those things. So first of all, the obstetric airway is more prone to be a difficult airway because due to hormonal changes, you have a lot of mucosal swelling, airway edema, and capillary engorgement. This causes the internal diameter of the trachea to be smaller. And oftentimes, if these women have been laboring, although you've done an airway exam upon admission, after hours and hours of laboring, their airway exam can change. And so it's prudent to repeat the airway exam once you enter the operating room as soon as you can. In addition, there's also breast engorgement, which may affect your ability to DL or what blade you use because of hitting the chest with your blade. Another system that is affected is your respiratory system. And so due to hormonal changes, progesterone increases your minute ventilation, mainly from an increase in tidal volume, larger than your increase in respiratory rate. Of course, due to the gravid uterus, you have increased abdominal girth. And so when turning supine, you have decreased functional residual capacity. And you also have increased oxygen consumption. And so these two combined, the closing capacity of your lungs is not affected, but this equals a faster desaturation during apneic time once they're not breathing on their own and you're inducing them. And so how does this affect our airway management? Well, one, with the airway exam, you have higher Mallampati scores. Two, you have higher risk of a difficult or a failed mask ventilation and intubation, 8 times more than the regular person. You have increased risk of mucosal bleeding. And so that first attempt at DL or VL or laryngoscopy is your most important attempt. As subsequent attempts, you'll have increased swelling and increased bleeding. And so this affects your endotracheal tube choice. You want to go for a smaller endotracheal tube, such as a 5.0, a 6.0, or a 6.5. You want to avoid nasal instrumentation or intubation, and you always want to have backup equipment in case your first attempt doesn't work. Also, due to these changes of increased minute ventilation, you want to maintain a CO2 or a partial pressure of CO2 around 30 millimeters of mercury. Although in a true stat C-section, the baby is usually delivered within minutes, and so this may be less relevant in a true stat C-section. Gastrointestinal changes. And so unfortunately, these patients that are higher aspiration risk, they have a higher incidence of GERD or gastroesophageal reflux disease. And so this is due to a decreased lower esophageal sphincter tone and the change in stomach positioning within their abdomen. And so there's displacement or rotation of their stomach, and this displaces the intra-abdominal esophagus into the thorax, and therefore the lower esophageal sphincter that is usually keeping the stomach closed between the esophagus and the stomach is no longer functional. And so that's why there's a reduction in LES tone and due to progesterone.
Okay, excuse me. Would you please enlarge your screen so that the participant can see the screen, the content easily? Enlarge, increase
the font size?
Yeah.
Yeah, of course.
Yeah.
I might have to do it every single slide though, unfortunately.
Well, you know, it's better right now. Just the screen, it's bigger.
Just presentation mode, I think,
Yeah.
maybe.
Oh, was it sharing the presentation mode?
You can show it again.
Okay, I'll try again. Let's see. Is it the same?
Yeah.
One-
It's perfect now.
yeah,
Yeah.
okay, yeah.
Okay. Thank you, everyone. Sorry about that. Okay. So to finish up gastrointestinal changes, there's no change in gastric emptying or gastric volume or gastric pH in pregnancy alone. However, they are affected during labor. Lastly is aortocaval compression. And so to avoid maternal hypotension, you need to have a 30-degree tilt or left uterine displacement. And this starts at 20 weeks of gestation. Once the patient is supine on the operating room bed, there is decreased right atrium filling of the heart. And therefore, there's decreased stroke volume and cardiac output, resulting in decreased blood pressure and uterine blood flow, which can result in decreased fetal heart rate. And so these are just pictures here showing that the aorta and the IVC, or the inferior vena cava, are compressed by the uterus. And so to wrap it up, with this edematous airway, there's a risk for failed intubation about 1 to 250 or 1 to 450, so 1 in 300 on average, versus 1 in 2,000 for all patients. There is rapid desaturation due to decreased functional residual capacity and increased basal metabolic rate or oxygen consumption. Aspiration risk is much higher, 1 in 500 versus 1 in 2,000 for all patients. There's increased intra-abdominal pressure and the relaxed sphincter tone that we were talking about, especially in the supine position, and then the aortocaval compression. So why would we have an emergent delivery? Who is at risk of a stat general anesthetic in the obstetric realm? Basically, any patient on the labor delivery floor, any antepartum patients that are under observation due to various things such as twins or placenta accreta spectrum, and basically anyone walking into the hospital that's pregnant. Why is it indicated? Depending on various factors such as severe fetal distress, mother can be bleeding or hemorrhaging due to trauma, placenta accreta, or placenta previa. They can have a prolapsed umbilical cord, a uterine rupture due to trial of labor after a C-section or prior history of myomectomy. They also might need an XLAP depending on trauma or how they're presenting. And we'll talk about how at the very end. And so one of the first indications is fetal distress. And so here we categorize the fetal heart rate tracing into 3 different categories: category 1, category 2, or category 3. Category 1 and 3 are more strictly defined. Category 1 is completely normal, and you'll proceed with routine care, a normal baseline heart rate with no decelerations except early decels, which are completely normal. Category 3 is completely abnormal, which requires the obstetrician to resolve the cause immediately, such as a sinusoidal pattern, absent variability with recurrent late decelerations, recurrent variable decelerations, and fetal bradycardia. These are all indicative of an abnormal fetal acid-base status when the strip looks like this. Category 2 is everything in between, and so these patients are usually kept on the monitor for prolonged periods of time and seeing if it'll resolve on their own or with small interventions. This can be minimal or marked variability, recurrent variable decelerations, prolonged decelerations to a certain degree, recurrent lates, or variables with other characteristics that are concerning. And so in the case of a category 2 or 3 tracing, the obstetrician may attempt intrauterine resuscitation to avoid a C-section. So the mother can change positions, maybe try to decrease aortocaval compression, can give the mother oxygen, IV fluids, pressors if the mom is hypotensive. They can turn off oxytocin to prevent further uterine contractions, to decrease the stress on the fetus. And basically in this setting, the goal is to provide rapid anesthesia if none of these work. But also providing rapid anesthesia without jeopardizing maternal safety or increasing fetal asphyxia or oxygen levels. And so how do you do this? Here we choose between neuraxial anesthesia or general anesthesia based on the clinical situation. So I'll talk about both of those. And so how do you decide between the two? There are many factors. Basically, how compromised is the mother or the fetus? Maternal, you're thinking about how poor does her airway exam look? What comorbidities does she have? Her volume status, if she has underlying coagulopathy. How timely are you able to achieve neuraxial versus general anesthesia? Or how experienced are you with neuraxial anesthesia, if you can do it in a timely manner or not? Basically, you're discussing with your OB team how severe the fetal asphyxia or the category 3 tracing is. What is the diagnosis? How urgent is the situation? And how concerned are you about the patient? General is often very fast going off to sleep, but there is maternal risk. Otherwise, neuraxial here is often preferred if time allows. And so contraindications to both. With neuraxial anesthesia, you do not want to pursue it with cardiovascular instability, hypovolemia, expected large volume hemorrhage when you're expecting to transfuse the mother, low platelets, and of course, if patient refuses. For general anesthesia, you're thinking about a poor airway, history of malignant hyperthermia, and patient refusal, of course. So here we try to avoid a stat general anesthetic as much as possible. And so you're thinking about fast-acting local anesthetics like chloroprocaine in your neuraxial anesthetic, or you're thinking about intrauterine fetal resuscitation, as we talked about already, with optimizing mom's position and blood pressure, oxygen, considering tocolytics like terbutaline or nitroglycerin spray, and then continuing to check fetal heart rate. And so say with all of that, baby's heart rate improves, then you have time to perform neuraxial anesthesia. And so of course you bring the patient into the room, you connect your IV, your monitors, oxygen, you can consider an antacid and consider continuing fetal heart rate monitoring. And then you perform your procedure. You can perform a quick spinal or combined spinal epidural, or even if the epidural catheter doesn't thread into the epidural space, you can consider a continuous spinal anesthetic, or you have an intrathecal catheter, especially in a difficult placement. You can bolus your epidural quickly if they have an epidural in place with chloroprocaine or lidocaine, and then use adjuncts as needed. And of course, treating hypotension early, which I know we'll talk about in 2 days' time. Of course, if that block doesn't set up, or if baby's heart rate changes and the circumstance changes, you always have to be prepared to change your plan. And so finally, at what we do in terms of an obstetric GA. And so when this patient comes in, you always want to perform a focused history, which includes past medical history, but also with targeted questions about your contraindications to uterotonics, such as asthma, high blood pressure, preeclampsia. If they've had any prior anesthetics or prior general anesthesia, to uncover a history of malignant hyperthermia if applicable. If they have any allergies to medication, and plus or minus their NPO status or the last time they ate or drank something. Of course, even if you already have a documented airway exam, perform an airway exam again. And in these emergent situations, it's very easy to become overwhelmed by the emergency with a lot of people in the room. And so you always want to explain to the patient what's happening and taking those 2 seconds to do so. You always have continuous fetal heart rate if possible, until they're able to prep and drape. And then you always want to make sure you're set up prior to induction. And so your IV access is working, your monitors, your ventilator, your antacid with a non-particulate like Bicitra or sodium citrate. Difficult airway equipment. And so here at Stanford, if the airway exam is concerning, we always go to video laryngoscopy first to increase our first pass attempt success. And then other special equipment. In the case of a hemorrhage, do you want an arterial line set up, resuscitation like a rapid infuser, blood products in the room, things like that. And then finally, you can start pre-oxygenating your patient, perhaps with the help of a nurse in the room holding the mask while you're getting everything else ready. And then positioning the patient with left uterine displacement or a bump on their right side, and then tilting their bed, perhaps 30 degrees, their head of bed up to prevent aspiration risk. Next, you want to make sure everyone is ready. So the patient is prepped and draped. The surgeon and the pediatrician are available and ready to perform the procedure. And then you can induce general anesthesia. We do a rapid sequence intubation because of the increased aspiration risk. We start with propofol, 2 to 2.5 milligrams per kg. You can also consider midazolam, etomidate, or ketamine, other induction agents if the patient's hypotensive. I myself have seen induction with midazolam 10 milligrams and then just a small amount of propofol to avoid hypotension in a bleeding patient. And then for your paralytic, something very fast acting, such as succinylcholine, 1 to 2 milligrams per kilogram. You can invest in the help of the people around you so they can assist with cricoid pressure during induction. Again, we're using the smaller endotracheal tube, and we're always prepared for a difficult airway. With these emergency obstetric general anesthetics, there's an increased risk of awareness, especially with multiple or prolonged intubation attempts, so something to keep in mind. Once you do secure the airway, then you inform the surgeon to start or cut, and using very precise language instead of, okay, we're ready, when you might be talking about induction. It's always very important to secure the airway and be clear with your language. Just as an aside, the obstetric difficult airway algorithm is not much different from our difficult airway algorithm for normal patients, except you're always using your best attempt at laryngoscopy as your first instead of a rescue. So that's why commonly we use video laryngoscopy first. Then you're calling for help and mask ventilating in between attempts if you're unable to get on the first pass. So now we've secured our airway and we require maintenance of anesthesia. And so our formula usually changes before and after delivery due to baby's delivery and exposure to general anesthesia. So before, we usually use a 50-50 nitrous and oxygen combination with 0.5 to 1 MAC of volatile anesthetic. And then after, you're increasing to 70-30 nitrous oxygen and decreasing volatile anesthetic to decrease uterine atony. Of course, because it's a general anesthetic, you need to be prepared for uterine atony. And so you're utilizing your uterotonics and secondary uterotonics, such as oxytocin, methyl ergonavine, carboprost, and misoprostol. And then you can also transition to a total intravenous anesthetic with a propofol-based anesthetic instead of using higher doses of volatile anesthetic. This is a very painful procedure, and so something to not forget is if they did not have an epidural in place that you can dose up after the procedure. You're thinking about a multimodal pain regimen for them. First, you can start with opioids with short-acting fentanyl, a longer-acting morphine bolus or hydromorphone bolus. You're using acetaminophen, ketorolac, or NSAIDs. And you can also consider midazolam 1 to 2 milligrams for amnesia, given that they do have the higher risk of awareness during this procedure. You can also think of other regional techniques, such as a transversus abdominis plane block for the abdominal incision, or asking your obstetric team to use local anesthetics injected around the wound or around the incision site prior to emergence. A lot of these patients also use patient-controlled IV analgesia, where we set up hydromorphone or other opiate infusions at their bedside that they can control on their own to prevent delays in pain management care on the nursing floor. So now that you've taken care of their pain and the procedure's all done, you're thinking about paralytic reversal. You can use glycopyrrolate with neostigmine, or you can use Sigamidex, although Sigamidex does have some risk of affecting lactation after delivery. And then lastly, you want to extubate when the patient is fully conscious. To decrease aspiration risk, you also want to perform orogastric suction with an orogastric tube, optimizing position by placing the patient upright or semi-upright with 30 to 45 degrees head of bed up, or putting them in the lateral position. And so back to our case. With our patient in early labor with multiple prior C-sections in another country where you may not have the records. She has placenta previa. Why is the C-section urgent, and what are you concerned about? Does anyone want to take a crack at it?
Okay, that 1 minute for the people thinking a little bit about the case. And if any one of you have the answer, please raise your hand.
I do want to correct this.
Okay, Dr. Phương, please.
Yeah, hello. Yeah, I'm Phương. I'm the third year resident, and thank you for your presentations. About your case presentations, this session, I think it is not the urgent surgery. That's maybe the elective surgery, and the time decided by the patients with the orthopedist doctor. The next question is the what are you what I can what am I consider about that? Because this case the patient had the placenta previa, so I will worry about the bleeding when they start the surgery. That the and like because maybe the surgeon will take needs more time for this case if the bleeding is cold. So usually we will perform the GA for this case, and with your presentation we know that the patient have a lot of the problem that we must consider, like the difficult airway, the aspirations, or the autocamber compression. Yeah, that's my answer, and thank you.
No, thank you. Exactly right. So we're concerned about bleeding. We're concerned that this patient has had multiple prior cesarean sections. And so perhaps it's a longer procedure with also increased bleeding with lysis of adhesions from prior surgeries and things like that. Also something to consider is with a placenta previa and prior C-section scars on your uterus, there is a higher risk of having placenta accreta, where the placenta is adherent to the uterine wall. And so there's higher risk of uterine rupture at the prior C-section scar. You also don't know if it was, what kind of incision was done on the uterus multiple times. And so they're at higher bleeding risk, as you were saying, higher longer procedure perhaps. And so you do want to be prepared for massive blood transfusion or the possibility of a hysterectomy after the case or during the surgery. Another question, and this is our last slide, I promise. And so a parturient is brought into the operating room for fetal bradycardia, and general anesthesia is induced with propofol and succinylcholine. The first attempt at intubation with a Macintosh blade is unsuccessful with a grade 4 view. Which of the following is the next best step in management? So first, you can attempt bag mask ventilation with cricoid pressure and release cricoid if it seems to inhibit adequate mask ventilation. After the first attempt, you can insert that's a typo, supraglottic airway device, like a laryngeal mask airway. Third, you can proceed with another attempt at laryngoscopy. Or lastly, you can wake the patient up and perform regional anesthesia or a neuraxial anesthesia block.
You can type the answer in the chat box. All of you can answer the question. Okay, you have a question? You have the answer?
Yes.
Dr.
Of
Quân?
course. No, I also struggled with this. And so after your first attempt at intubation, of course, because this can be a prolonged intubation attempt, exactly, thanks, Fung. So you're actually going to attempt bag mask ventilation between your attempts to make sure your mom isn't getting too hypoxic and therefore affecting baby. Of course, with cricoid pressure, sometimes you're unable, due to all the airway swelling, to perform adequate ventilation. And so if it inhibits your adequate mask ventilation and oxygenation, then forego cricoid pressure. And that's it. Thank you so much, everyone. I appreciate it.
Thank you, Dr. Olako. We can call you Karen, right?
Please, yes, it's much easier.
Okay. So I would like also introduce Dr. Karen is the chief president, right? Of your CI3. So that's why you have the very good preparation for your lecture, and the way you present it very good one. Everything is quite clear and easy to understand for our resident. So we come back a little bit for discussion part. If you guys have any more question or discussion with the topic anesthesia for emergency delivery, so you can write the question in the chat box or you can answer the question. Raise your hand. For the first question, I would like to know what is the rate of the GA in emergency delivery in Stanford University. How many percent?
That's a great question. I don't know if Dr. Stroud can weigh in, but our department chair, a conversion from neuraxial to general anesthetic is around 5 to 7% at Stanford from Dr. Carvalho. Unfortunately, no, I think that's all I know. Yeah.
You can, we can get the answer and tell them on Friday, the Q&A session.
Yeah. I think it's quite similar right now in our hospital, just less than 10%, I think. Yeah. But I read some article in the other hospital, the other country, like in Africa country, the rate of GA more than 50% is very high, right? So most patient we do with spinal block, spinal anesthesia. And my second question is, so in case the patient can do with neurological anesthesia, but the patient scared about the weight during the surgery, and the patient refuse to do the regional block. So how can we explain to the patient in your practice?
Yeah, I will say that some of our patients are very anxious or concerned that they're going to be awake during the procedure, because surgery is scary for anyone. We do explain to them that with neuraxial, whether it's a spinal or an epidural technique, they will be comfortable and numb for the entire region where they're working. So we usually say from the breasts down, you're numb and you may feel soft touch or pressure, but you shouldn't feel any intense pain. And because this is the safest option for them with regards to intubation and aspiration, their partner is also able to stay in the room if they're nice and awake, and they're also able to do skin to skin, where once the baby has their checks by the pediatric team, the baby's able to rest on mom for the duration of the procedure. And so all of these things try to reassure them that they're still going to be safe and comfortable despite them being awake. However, the way that we also phrase it in our consent process is, instead of saying it's a backup plan or it's the last thing we want to do or our last resort, being a general anesthetic, we just say that if you're not comfortable enough or we have safety concerns for you and for baby, then we'll transition to a general anesthetic. And this is just to keep you and baby safe and comfortable, instead of saying this is the last resort and we want to avoid it at all costs, because that will also instill more anxiety and more fear in the patient.
Yeah, I do agree with you. Sometimes we have some patient very scared, very anxious about the operation. So we take a long time to explain to the patient and the families. Yeah. And I had another question about the case, your case in placenta previa, but in not the previous C-section, but in the patient with first time pregnant, and maybe the placenta is not in the anterior wall, but posterior wall. Sometimes in our practice, the children, the objections, they do agree that we can do by spinal block, because they confident about to control the bleeding. So what about your practice on the placenta previa? Must do by GA, or that depend on every kind of patient?
Yeah, it's a great question. I've had 2 months on my obstetrics rotation now, and if the patient is massively hemorrhaging or actively bleeding from their placenta previa, we will still do a neuraxial anesthetic if able.
Yeah.
Otherwise, if not, and there's no time to do the neuraxial, I've done a stat GA. So it just depends on what, if it's their first time being pregnant also, that makes us lean towards a little bit of the neuraxial anesthetic to avoid the general anesthetic. But I've seen it both ways because sometimes the baby's at danger from all of the bleeding.
Okay. We have a question from Dr. Vin.
That's a great question. And so, do you use fentanyl before intubation for cesarean section surgery? We do not. I have not used fentanyl on intubation. One of the things you also want to consider is if you have a preeclamptic patient, because they can have an even higher swing in their blood pressure as a reaction to laryngoscopy. We have been taught that fentanyl won't kick in fast enough, and it also doesn't go away fast enough. And so we've been taught to use boluses of remifentanil, which is a shorter acting and immediate acting opiate anesthetic that'll wash away very quickly in preeclamptic specifically. However, I haven't seen us use fentanyl for obstetric GAs, but we definitely use it for all our other GAs and other patients.
Mm-hmm. We don't use too much remifentanil in our practice. That's why sometimes in the preeclampsia with a very high blood pressure, we sometimes we use a small dose of the fentanyl, just around 50 microgram to prevent the hypertension in the intubation.
Yeah.
And sometimes we combine a little bit with lidocaine, for example, to stop sympathetic stimulation.
Yeah, we've also seen people use esmolol to blunt that sympathetic surge. Another question. So can you explain more about the difficult airway management strategy? Have you had any difficult airway challenges with C-section cases before? Yes, so the difficult airway management strategy is very, very similar to the difficult airway management strategy. Let's see if I can just go back to our slides and share it again. Let's see if I can share. Yeah, and so you're starting here at the top. You want to intubate using your best attempt at laryngoscopy, and so usually that means going straight to video laryngoscopy. If you're successful, then you go forward with your cesarean delivery. And then if not, unfortunately, you don't want to change to your second mode of intubation just yet because you want to make sure you can mask ventilate. Also calling for help or more providers if you're able, and then moving on to intubating using an alternate technique. And this time you can change the size of your blade. You can change to video laryngoscopy. If you started with direct, you can change your endotracheal tube size if it was difficult passing the tube. They also say to avoid redosing succinylcholine. And then after 2 maximum attempts, and you're not able to mask ventilate, then you're moving on to a supraglottic airway device, LMA, or a surgical airway. I fortunately have never had a true difficult airway during a cesarean delivery. I will say that a lot of the airways I have done on C-section, and I've only done less than a handful, the airway is very edematous, and it was very difficult passing the tube. But good thing we had good pre-oxygenation and we had the time to do so. So we didn't have to advance to a laryngeal mask airway or a supraglottic airway device or a surgical airway. Because especially with all of the edematous tissues, a surgical airway is going to be very difficult in these patients. I also saw when preparing for this presentation that leaving a laryngeal mask airway device and seeing that it's seated properly can be your secure airway for the duration of the procedure if you're unable to intubate, as adequate ventilation and oxygenation is your true goal. Of course, they are at higher risk for aspiration, especially if the laryngeal mask airway doesn't seat properly. But it is your rescue device and can be used as your final destination if necessary. You don't have any other options. Thanks for your question.
Any more question? Dr. Thao, please.
Thank you, Karen, for your letter. So I would like to discuss about your case. So we know placenta previa have three types: marginal, partial, and complete. So which one do you prefer to perform GA, and which one will perform spinal block in your practice? Thank you.
Thank you. For placenta accreta spectrum, a lot of our fellows do those cases, and we actually perform those cases in our larger hospital settings, so we have more resources. The ones that I've seen as true emergent stat C-sections that are unable to go to our larger facility, they've all been general anesthetics on our smaller labor and delivery floor, because there was never enough time to perform neuraxial anesthesia, as the two that I've seen in 2 months, so it's quite rare for it not to be a planned delivery, but in a stat GA that I saw, there was no time to perform neuraxial because they had already unfortunately hemorrhaged 1 to 2 liters on their bed, and they were antepartum patients, and so they were just under observation for weeks at a time on our other unit. And so we did GAs. Whether that was preferred or not, I think it was just the safest thing at that point. Thank you.
I makes sense. Thank you.
Another question is, do you perform any regional techniques other than TAP? Do you use intrathecal morphine? I myself haven't used a TAP block at all for our patients, because usually they may have a neuraxial catheter in place, or I didn't finish the case and we didn't do a TAP block and there was local infiltration by the obstetrician. But I can imagine that you may be able to do other neuraxial or other regional anesthesia techniques like a rectus sheath block or serratus anterior or things like that. But we also use intrathecal morphine at the end of every intrapartum C-section, or it's also included in our spinal injection or epidural placement. And so our formula is usually bupivacaine if there's enough time for it to set in, with some intrathecal fentanyl and intrathecal morphine. We usually use 15 micrograms of fentanyl and 0.1 milligrams or 100 micrograms of morphine if it's intrathecal.
Yeah, it's similar in our practice. Just for spinal block, we do the combined with fentanyl and morphine for anesthesia post operation. But in case the patient with GA, it not reasonable to do the spinal injection morphine, right? So we choose the other option like the regional block, like the TAP block or QR block, that have the patient relieve the pain. And in the multimodal anesthesia, that in your answer, I know about in case the patient have already the epidural catheter for laboring, and after that the patient converts to the C-section. and we will continue the epidural for neurosio anesthesia, and we keep continue to the both surgery, both operation, pain management too. But somebody they don't want to use the continue the epidural catheter because they want the patient stand up and walk early, because the epidural catheter is make the patient weakness and hard to walk around earlier. That's why they remove the catheter and they use the regional block like the TAP or like QL sometimes, yeah. So maybe they change a little bit the technique.
Yeah. After if they have a labor epidural in place for their C-section, we usually give them epidural morphine and then discontinue the catheter. And we still see quite a bit of urinary retention, although they are usually walking by the end of the day or the next day if it's an evening C-section.
Yeah, that's a good option. And in the medication for neurosio, I saw in your presentation you use 3% of chloroquine, but
I have never used it,
yeah,
but it is an option. I've seen some people use like 10 cc's of chlorprocaine if they need it immediately.
it's more short onset in compared with lidocaine, right?
Yeah, it's a shorter onset, but then it'll also last much shorter, and so it requires redosing.
But you can repeat again second dose, or you combine half the lidocaine, half the chloroprocaine.
Yeah.
Yeah.
Sometimes in my elective C-sections, the lidocaine takes a little bit to, with everyone being a little anxious, it takes maybe too long sometimes to set up.
Okay. Any more questions from you guys? Dr. Min, you have any comment?
It's okay for the lecture. Yeah.
Sorry, I didn't hear that.
Yeah, Dr. Min, you continue. Okay, thank you, Dr. Min. Yeah. Any more questions, Dr. Saha? Are you
Yes.
here?
Yes, I'm here.
Okay.
Yeah, I have a question
Doctor-
for you. Yeah. If the patient have a C-section spinal anesthesia, the patient have used morphine, spinal morphine. Do you use prevent and treatment post-operative nodules and vomiting prophylaxis for the patients?
PONV, you mean?
PONV
Yeah.
prophylaxis. And what drug do you use for PONV for the patient?
Just to repeat, what medications do we use for PONV for the patient?
Right. Because
yeah,
you know the spinal morphine is the high rate of the PONV.
PONV, yeah.
So sometimes we prophylaxis with a couple of medication in the patient with intrathecal morphine.
Intrathecal morphine, right? Yeah. So we use 2 medications. We use ondansetron 4 milligrams and dexamethasone 8 milligrams if they're not diabetic. If they're diabetic, then we use dexamethasone 4 milligrams. So we use those 2. Their third line rescue is metoclopramide or compazine, but at that point, unfortunately, it doesn't work too well. Yeah, those are what we use for PONV.
Dr. Sanha is the previous president in our university. So now, right now, she's attending right now.
Amazing.
Yes, thank you.
Okay, so let me a couple of minutes to explain in Vietnamese to our residents, because some of them is first year resident and they have to understand all of your lecture. Như vậy là hôm nay thì chúng ta đi bài đầu tiên về cái gây mê cho phẫu thuật lấy thai. Thì trong trên bài của cô Karen hôm nay thì có hai cái nội dung chính. Thứ nhất là cô trình bày về thay đổi về giải phẫu sinh lý trong phụ nữ mang thai, thì cái này thì chúng ta cũng đọc nhiều rồi. Sinh lý phụ nữ mang thai cái này cũng trình bày cơ bản lại thôi. Thay đổi về tuần hoàn, hô hấp, rồi đường thở, rồi tiêu hóa, chèn ép tĩnh mạch chủ, vân vân. Nói chung cái này thì các anh chị đọc là rất được. Cái thứ hai thì cô nói về gây mê cho phẫu thuật lấy thai. Thì trong này cũng có hai cái. Thứ nhất là những cái bệnh nhân nào thì thường phải là gây mê cần để phẫu thuật. Thì tất cả những bệnh nhân mà trong quá trình chuyển dạ của họ đều có thể là gặp những cái trục trặc, những cái bất thường và cần để phẫu thuật. Rồi những cái bệnh nhân mà có những cái chỉ định phẫu thuật khác thì chúng ta cũng liên quan về đến mẹ, đến con, và những cái chỉ định liên quan khác. Thì trong đó suy thai là một trong nguyên nhân mà quan trọng để mà chỉ định phẫu thuật lấy thai. Trong đó là đặc biệt là suy thai độ 1, độ 2, độ 3, độ 1 thì tim thai bình thường, độ 2, độ 3 thì có thể là những cái chỉ định mà người ta cân nhắc phẫu thuật. Thì trong cả cái phẫu thuật lấy thai thì nó cũng có chia mức độ đấy, chúng ta biết rồi, mức độ khẩn cấp và mức độ cấp cứu thôi. Những mức độ mà nhấn ấy, cần lấy thai nhấn ấy, thì nó cần phải gây mê rồi. Thì ở thực hành hiện nay thì ở Mỹ thì người ta thường cũng giống như ở Việt Nam nhiều nơi thì người ta đa số người ta làm giảm đau ngoài bằng cứng, một tỷ lệ khá là lớn ở tất cả bệnh nhân mà chuyển dạ. Thì người ta có thể là nếu như mà nó không khẩn cấp lắm thì người ta có thể là tiêm cái tai ngoài bằng cứng, hoặc là người ta gây tê tủy sống nếu như bệnh nhân chưa có cái tai ngoài bằng cứng. Đấy. Thì liên quan đến cái tê này thì lúc nãy có trình bày ấy, là người ta có thể sử dụng chlorprocaine. Đây là một cái thuộc nhóm ester 3%, tiêm 10 ml. Thì cái này thì thuốc này nó tác dụng khởi phát bệnh nhân hơn so với lidocaine. Tại vì khi mà chúng ta mổ lấy thai chúng ta cần thời gian nhấn. Thì trong khi mà lidocaine ngoài bằng cứng này thì nó có thể là 20 phút trở lên nó mới bắt đầu đạt được cái hiệu quả, mà như vậy bệnh nhân phải chờ đợi lâu. Thì người ta có thể sử dụng chlorprocaine, nhưng mà cái này thì nó lại ngắn, tầm khoảng 20 phút để 30 phút. Nếu mà mổ dài thì nó lại hết, thì chúng ta có thể lặp lại, hoặc là chúng ta phối hợp lidocaine sau đó chúng ta làm tăng kéo dài tác dụng. Cái thứ hai thì gây mê thì chúng ta sẽ gặp những cái vấn đề như chúng ta cân nhắc khi nào thì chọn gây mê hay chọn gây tê. Thì nhiều cái yếu tố chẳng hạn như là liên quan đến yếu tố lâm sàng thì chúng ta cũng biết rồi, cái nào thì có chống chỉ định gây tê thì chúng ta phải gây mê. Cái thứ hai là về cái liên quan đến thời gian khẩn cấp, mức độ khẩn cấp ấy, thì chúng ta cần phải chọn gây mê hay gây tê. Một số cái nếu mà gây tê thì chúng ta cân nhắc một số cái chống chỉ định, ví dụ như là nó mất máu nặng, nó giảm thị tiết tuần hoàn chưa bù được, nó có bệnh lý tim mạch nặng, hoặc là nguy cơ chảy máu cao, những cái trường hợp đó. Còn gây mê thì chúng ta biết là những cái khó khăn như là nội quản khó hay là trào ngược, thì tất cả những cái vấn đề đấy thì chúng ta cũng cần phải chú ý khi lựa chọn gây mê và gây tê cho bệnh nhân. Và một số cái ca lâm sàng cô trình bày thì đây là một phụ nữ họ có mấy lần mổ lấy thai rồi, 3-4 lần rồi đúng không? Thì hiện tại họ vô thì một cái nhau tiền đạo mà bệnh nhân là chuyển dạ, thì cái này thì người ta là một cấp cứu trong sản khoa rồi, người ta phải theo dõi là kỹ. Và thường thì những ca này nhau tiền đạo mà nếu mà trên một cái nền vết mổ cũ ấy thì nguy cơ là nó chuyển thành nhau bám nhau ca năng lượng, tức là xuyên cơ, vì cái chỗ mà mổ lấy thai nhiều lần đó, là cái cơ nó rất là kém, nên là nhau nó sẽ bám sâu vào trong cơ ấy. Niêm mạc nó kém thì nhau nó bám sâu vào và nó nguy cơ nó chảy máu, và mổ thì nó mất máu và nguy cơ phải cắt tử cung, thành ra cái khả năng cao là chúng ta gây mê. Thứ hai nữa là bệnh nhân vết mổ cũ nhiều lần rồi thì nguy cơ nó mộng cái vết mổ, và nguy cơ nó vỡ tử cung trong quá trình chuyển dạ. Thì chúng ta cũng phải theo dõi để mà xử trí cho bệnh nhân. Thì cái ca lâm sàng của cô thì cũng nói về cái mức độ cấp, và chúng ta chỉ định để gây mê cho bệnh nhân thôi. Một số câu hỏi của các anh chị thì liên quan đến vấn đề kiểm soát đường thở cũng như là sử dụng thuốc trong gây mê, trong chống nôn. Thì đối với gây mê thì chúng ta biết là chúng ta chỉ chuẩn bị tất cả mọi cái xong xuôi rồi thì chúng ta lâm sàng chúng ta đã có, nếu anh chị nào gặp cả cái ca mổ lấy thai ở chúng ta thì chúng ta đã hiểu được cách chúng ta làm, đúng không? Tất cả mọi việc xong xuôi rồi chúng ta mới khởi mê. Và khởi mê thì ở cô thì họ cũng, nếu mà bệnh nhân mà không có giảm thị tiết tuần hoàn ấy, chúng ta ưu tiên dùng propofol. Đấy. Còn nếu như mà nó có mất máu đâu trước đó thì người ta là có thể chọn midazolam, etomidat hoặc ketamine để khởi mê nếu như bệnh nhân có mất máu nặng trước đó. Còn lại thì propofol và succinylcholine. Đấy. Thì bác sĩ bác sĩ nào có hỏi là có dùng fentanyl không? Thì fentanyl của họ thì họ ít dùng là vì nó ức chế hô hấp của trẻ. Thì trường hợp nào tăng huyết áp thì người ta dùng sulfentanyl, remifentanil. Thì cái này nó tác dụng nhanh và ngắn, nên ra có thể chúng ta tiêm vào thì nó nếu mà có quá bên con thì nó cũng máu hết, nên ra là nó ít ức chế hô hấp của trẻ hơn là fentanyl. Còn lại thì chúng ta lâm sàng chúng ta vẫn dùng xài fentanyl nhiều. Một số câu hỏi khác thì chắc cả anh chị cũng đã thống nhất cả rồi. Tôi thấy cũng không cần thiết phải nói sâu nữa. Thì giảm đau thì của họ thì cũng rất là nhiều loại, cũng giống như của chúng ta cả thôi. Tuy nhiên thì nếu mà giảm đau có cái ra ngoài bằng cứng rồi mà sau mổ lấy thai thì thường người ta cho thêm morphine đưa ngoài bằng cứng, thay vì người ta truyền liên tục thuốc tê để giảm đau. Thì như vậy lúc nãy tôi gọi ý kiến là nó gây yếu chân và sản phụ nó không đi lại sớm, thì người ta có thể cho morphine ngoài bằng cứng. Thì các anh chị chúng ta thấy là morphine ngoài bằng cứng thì nó sẽ nó ngấm vào tủy sống và nó sẽ tác dụng tương tự như morphine tủy sống. Liều thì khoảng 10 đến 15% morphine ngoài bằng cứng nó sẽ vào được trong tủy sống. Thành ra là các anh chị dùng ngoài bằng cứng thì khoảng 2 đến 3 mg ra hoa này chúng ta tiêm ngoài bằng cứng thì nó sẽ hấp thu vào được trong tủy sống, với liều nó gần bằng khoảng 0,1 mg, tức 100 microgram trong tủy sống. Cơ bản là như vậy. Okay, I'm sorry, Karen.
No problem.
A little bit is late to our resident. Dr. Sanha, you had more discussion.
Dạ không thầy, em hỏi một xíu về cái ketorolac thôi thầy. Tại vì ở bệnh viện em á là phụ nữ mà mang thai á là không được dùng ketorolac. Cái những bệnh nhân mổ lấy thai tụi em mà dùng ketorolac á là bị bị giật, nó không cho. Nó bắt là tụi em giải thích. Thì giờ đối với những bệnh nhân mà đã mổ đẻ rồi hoặc là bé ra rồi có được dùng ketorolac không thầy? Với lại bệnh nhân mổ lấy thai thì mình vẫn được dùng nephobam không thầy? Nhưng mà thấy cái phác đồ giảm đau của chị đó hình như không có nephobam không thầy?
Okay, the question about ketorolac for pain management in C-section. What about the contraindication for ketorolac? Because you know, in Vietnam, the pharmacy, they recommend that we should not use ketorolac for pregnant for the C-section. And the second medication is the nefopam. Do you combine in your multimodal anesthesia? Nefopam, you get it? The medication.
The
Nefopam. I don't know. Maybe it's not common in.
Nefopam. I don't think we have that one. Nefopam.
Yeah.
Painkiller. Also,
Yeah, I'm not familiar with that.
yeah.
Yeah, you don't have nefopam in USA.
Yeah.
Only in France and the in the Francophone community.
Yeah.
Yeah.
Yeah, so I'm not familiar with nefopam. I don't think we have that. But ketorolac, as long as baby is delivered, there's no contraindication for for the later gestational ages as baby has now been delivered. Also, despite what people might say for bleeding risk, it's not something contraindicated on our end. But however, if the obstetricians are concerned about bleeding, they will say to avoid ketorolac, but otherwise, yeah. Oh, and then that's something I can look up too if it is contraindicated with breastfeeding or lactation.
Yeah, sometimes they said because the effect to the baby in case the patient had a breastfeeding. So they recommend to use diclofenac. Yeah, instead of ketorolac. Yeah. But I see in your practice you use quite common the ketorolac in OB, right?
Thanks, Dr. Stroud.
Thank you, Sarah. See you tomorrow. Okay, so I think today is a lot of discussion. It's very interesting and useful information. So tomorrow we start a case study from you. Okay, your case. And I asked our resident to prepare the other one for the next week. Yeah.
Okay.
And so tomorrow the case study, and Thursday is the hypertension.